Good afternoon and welcome to the Assembly Committee on Commerce and Labor. Committee Secretary, will you please take roll?
Assembly members Anderson, Carter, Cole, Hardy, Howdigy, Kasama, Miller, Monroe Moreno, O'Neill, Roth, Torres Fawcett, Yeager, Urick, and Chair Marzola.
I am here. Please mark Assembly Member Kasama absent excuse and mark Assembly members present as they arrive. Welcome to our audience here in Carson City, those joining us by video conference in Las Vegas, and anyone tuning in over the internet. Today we will be hearing three bills: Assembly Bill 183, Assembly Bill 186, and Assembly Bill 207. I will be taking those bills in order today. Before we get started, I do have some housekeeping announcements. Members of the public may provide testimony in various ways, all of which are listed in our agenda. When testifying, please remember to turn the microphone on to speak and off to listen. Also remember to state and spell your name for the record. Committee information is available on the legislature's website. You may also watch our meetings through the legislature's YouTube channel. We ask that public comments be kept to 2 minutes so that everyone can be accommodated. I expect courtesy and respect in all our interactions, even if we may not agree. Lastly, please turn off or silence all of your electronic devices, especially your cell phones. And with that, we will move to our first agenda item. I will now open the hearing on Assembly Bill 183. This measure revises provisions relating to optometry. Assemblymember Koenig. Welcome to Commerce and Labor on this great Monday. You may begin when you're ready.
Thank you, Chair Marzola, for allowing us to present today AB 183. My name is Greg Koenig. I represent Assembly District number 38. And let me tell you a little bit about this bill in front of us today. So the genesis of this is last session, I carried a bill for the Board of Optometry. And at one point, there was a part, so the Board of Optometry consists of 4 members, which, who makes a board with an even number? I'm not sure, but it currently sits at 4 members. And there was a part last session in the bill where 2 of the members were kind of leaning one way and 2 of the members were leaning the other way. And that left me kind of in the middle and not sure which way to go. So at that point, I approached the board and asked if they'd be amenable to add a 5th member to their board so that they would not have an even number anymore. And that was the main reason for me to want to bring this forward. And then since we were bringing this forward and it had to do with optometry, there's going to be some cleanup and a few little additions that the State Board of Optometry is recommending. Start with a couple of amendments right off the bat. We have decided to scratch section 4. So on page 4, lines 24 through 27, there was some concern by some members of the committee on this section here, and to deal with those concerns, we've decided to just eliminate that section. So section 4 is completely going away. In section 5, the words any analgesic or non-analgesic, we've replaced that with when prescribing an opioid, narcotic, analgesic, or non-analgesic. And talking about that a little bit more, I'm not 100% sure that all the way meets the intent and the needs. And so I'm going to turn the time over to President of the Nevada State Board of Optometry, Mariah Smith, to maybe explain that a little bit better, and then also go through the other parts of this bill.
Thank you. Members of the Assembly, I'm Mariah Smith, Board President for the Nevada State Board of Optometry. I'll go in order of the different sections, and I'll try to be brief just to go over it, and we'll go over Section 5 as well. section number 2, 3, and 11 are ways for the board to be able to enforce our laws and have licensees comply. Section 4, as Dr. Koenig noted, is gone. Section 5, the goal of changing it was to clarify what medications optometrists can prescribe and in what context. And so I think that we can collaborate on that with Dr. Koenig to get that language a little bit easier to digest and more clear. We're not really changing anything. We're just trying to clarify laws that were already in place. The rest of this is a bunch of cleanup, 6 and 7, as Dr. Koenig mentioned, adding a 4th optometry member to create a tiebreaker. Section number 8, there are different countries with different national boards that they have to take, and we are trying to clarify that in America, in Nevada, it has to be our national board that the licensees are taking to get licensed here. For number 9, the 40 hours of clinical training for pharmaceuticals, it is already incorporated in the optometry school curriculums that they are getting that training, so there isn't a need anymore for our optometrists to get 40 hours under a ophthalmologist to be able to prescribe pharmaceuticals. For number 10, another thing, we had that an optometrist had to be endorsed by a ophthalmologist to get glaucoma by endorsement, a Nevada ophthalmologist. But there are lots of good optometrists who would like to move to Nevada who've been working in a medical practice with an ophthalmologist in lots of different states, and that ophthalmologist could and should be able to sign off on their ability to treat glaucoma. Number 11, I already mentioned, just allowing us to be able to enforce our laws with our licensees. And then number 12 and 13, just clarifying that our laws also go to teleoptometry, not just optometry, but teleoptometry, telemedicine. Number 14, that there are 2 different categories of penalties. There are administrative ones, and there are ones that affect the public safety. And if there's an administrative thing, like I filed my paperwork late or I didn't send in my check, that those are not things that are going to be reported to the National Practitioner Database that I was penalized for something. And then number 15, we made a law a couple years ago because we had an optometrist die suddenly, and we needed to know how his family was able to pass along his optometry office when we say that an optometry office needs to be owned by an optometrist. And we wanted to extend that a little bit further to an optometrist who was permanently incapacitated. They should also have a route on how quickly they need to pass their optometry office into somebody else's hands. And then number 16 allows for citations and administrative fines when they're not harming the public. We would like to open it for any questions.
Are you ready for questions? Perfect. Thank you so much, and thank you for your presentation today. We'll start with Assembly Member Miller.
Thank you, Chair. I just have a brief question under Section 8. I believe it's Section 8 when you mentioned about those who had successfully finished the exam from the National Board and stating that it had to be for people through the, here I am, through the United States or Nevada. And I was just wondering, when it comes to those professionals coming from other countries, is there reciprocity, or what is the process for them?
Mariah Smith for the record. That is something that has been brought up and a couple of years ago, and I think that would be a great thing to move forward to in the future. But I don't think we've figured out what's on those tests, what those laws look like, what kind of optometrists would be coming from other countries. I think the training programs are really different in different countries. I know for Australia, for one, you can just be straight out of high school and go be an optometrist, where in the United States, you have to go to an undergraduate program, whether that's 2-year or 4-year. It used to be 4-year, and I think they're a lot at doing 2-year now, but it's different. So we would need to look and see really with each country what their standards are before we can go down there, but I think that'd be a great thing to move forward to in the future. Thank you.
Quick follow-up, Chair? Go ahead. Is there the ability now then for a practitioner from another country to just take that exam, or is it the process of you identifying what undergraduate or graduate courses they've taken and then initiate you could take the exam? You know, again, we're trying to get more, especially in the medical field, professionals working, so.
Oh, sorry, Mariah Smith for the record. That's a little bit out of our control because it's really the national boards who are doing that, and we just accept the tests, the people who've passed the national boards. But again, I believe this is an initiative that's not just new to Nevada or new to today. It's been in the talks for a couple of years. I think everybody recognizes there could be great practitioners from other countries, but the way the Nevada law currently is they need to pass the NBEO, the national boards that's provided in the United States. And I believe that they could pass that test from another country, even without the undergraduate stuff. But that's a little bit outside of what we're in charge of. Thank you.
Thank you so much. Thank you, Chair.
Committee members, any additional questions? Assemblymember Cole?
Hello, thank you so much for bringing this. My question is on Section 3, when we talk about the board reasonably determining from an investigation of a licensee that health, safety, or welfare is at risk, and then going into the process of then there being a up to 60-day suspension until a hearing happens. I just did a tiny little dive into how the contractors board handles things, and they specify some timeframes in which the complaint comes in and the timeframe in which the investigation happens. I think that might be a good add in here just to give the person some clarity.
Mariah Smith for the record, thank you for the suggestion. We'll work with Dr. Koenig and see if there's a way to make that work out.
Greg Koenig for the record. So I heard what you said, but I didn't all the way understand what you said. So what was your recommendation?
I hit it. If you look how the contractors board works, there's a time frame by which the complaint comes in, and then it's within, I believe, 10 days, maybe 10 business days, that investigation has to be done. And then that kind of verifies so the person really understands whether there's an issue. And then, because you've got the 60 days before the hearing happens, and 60 days is a long time for someone to wait.
Greg Koenig for the record. Thank you for that question. I think that's definitely something that we can consider and put in as amendment before, if we would get a work session.
Committee members, any additional questions? I don't see any. So a couple of things. Thank you for the proposed amendment, especially on Section 4 was the one I had a huge issue with. So I appreciate the removal of that. I have a question on Section 12, 13, where it states optometric telemedicine. And so in those sections, for the telemedicine, is there a pre-existing relationship between the doctor and the patient?
Greg Koenig for the record. I'll answer this one, and then if she needs to correct me, we'll go to her. I mean, that was one of the biggest parts of the bill that I brought last time, was to, implement and define telemedicine, just because for the rurals where I live, it can really make a big difference. I give the example of, I'm giving someone a pair of contacts. They have to come to my office and see that, and then typically I make them come back the next week to make sure that they work before I give them the final prescription. But I have patients routinely that come from 3 hours away, if not more than that. And this is, if everything's working just fine, that's a 5-minute appointment. So to make them drive 3 ways, 3 hours each way for a 5-minute appointment, for me to just say, yes, they're working, they're fine. That's one of those things we can do telemedically. But yes, they have to be an established patient with me, and then those follow-up types of visits we can do telemedically. It's not, I've never seen you before, you're on my computer screen, here's a pair of glasses, we'll catch you next time. That's not how that telemedicine is working.
Thank you for that response. And of course, I was here for that bill last session, and I know you worked a lot on it. And so I just wanted to get that on the record as well. Last chance, committee members. I don't see any questions, so I will give you guys a few minutes to move seats. We will hear testimony in support of Assembly Bill 183. Is there anyone here in Carson City wishing to testify? Please remember to state and spell your name for the record. You have 2 minutes.
Good afternoon, Chair Marzola. For the record, Danny Thompson, D-A-N-N-Y, Thompson, T-H-O-M-P-S-O-N. I'm here today representing the Nevada Optometric Association. We represent over 200 optometrists statewide. This bill is important. This board has done a good job, overseeing optometrists in Nevada, but as you can well imagine, a board with an even number of members creates situations that are pretty hard to deal with. And so I think the most important part of this bill for us is that, and we urge you to support. Thank you.
Thank you. Is there anyone else in Carson City wishing to testify in support? Don't see any. I don't see anyone in Las Vegas broadcast. Is there anyone on the line?
Testify in support of Assembly Bill 183, please press star 9 or raise your hand in the Zoom window to take your place in the queue. Chair, we have no callers choosing to testify in support at this time.
Thank you. We will move to testimony in opposition to Assembly Bill 183. Is there anyone here in Carson City? I don't see anyone. I don't see anyone in Las Vegas broadcast. Is there anyone on the line wishing to testify in opposition?
To testify in opposition to Assembly Bill 183, please press star 9 or raise your hand in the Zoom window to take your place in the queue. Chair, we have no callers choosing to testify in opposition at this time.
Thank you. We will move to testimony in neutral. Is there anyone here in Carson City wishing to testify in neutral? Don't see anyone. Still don't see anyone in Las Vegas. Broadcast, is there anyone on the line?
To testify in neutral to Assembly Bill 183, please press star 9 or raise your hand in the Zoom window to take your place in the queue. Chair, we have no callers choosing to testify in neutral at this time.
Thank you. Assemblymember Koenig, would you like to give any final remarks? I think we're good, thank you. Okay. Thank you for being with us today. I will now close the hearing on Assembly Bill 183. I will now open the hearing on Assembly Bill 186. This measure revises provisions governing pharmacists. Assemblymember Orenlicker, welcome. Please remember to state and spell your name for the record for your presenters. You may begin when you're ready.
Thank you. Good afternoon. I'm Assembly Member David Orentlicker, representing District 20 on the southeast side of Las Vegas. Thank you for the opportunity to present Assembly Bill 186. And I'm joined by some co-presenters who are on Zoom and here. The bill responds to a concern we've heard much about, the shortage of doctors and other healthcare professionals in Nevada. We need thousands more doctors, thousands more nurses, and thousands more other practitioners just to reach the national average. With such a serious shortage, it's essential that Nevadans receive the full benefits that our existing healthcare workforce can provide. We need to ensure that our healthcare professionals can practice to the full extent of their expertise and skill set. Unfortunately, that's not always the case. One area in which we unduly limit what healthcare professionals can do is pharmacy services. The expertise and skill set of pharmacists go well beyond what our laws allow them to do. This bill is designed to allow Nevadans to benefit more fully from the expertise and skills that our state's pharmacists possess by expanding the kinds of services that pharmacists can provide. Fortunately, we don't need to venture into uncharted territory. As my co-presenters will share, similar legislation has been successful in Colorado and Montana, and more expansive legislation has been successful in Idaho and Iowa. I will now turn to Ken Kuhnke, the Executive Director of the Nevada Pharmacy Alliance, to go through the background and the bill. He suggested this bill, and he's, I believe, with us on Zoom.
Yeah, thank you so much, Dr. Orentlicker and Chair Marzola and the members of the Assembly Committee of Commerce and Labor. My name's Ken Kunke, Kenkunke. I'm a practicing pharmacist here in Nevada, and I've been here since 2003. I also serve as the executive director of the Nevada Pharmacy Alliance. Today, I want to go over the substantive changes the first slide I have here on AB 186 is two terms that I just wanted to make sure that the whole committee was aware of. The first one is called a CLIA wave test. A CLIA wave test are those tests that are determined by the CDC or FDA to be so simple that they're a little risk of error. Think of like a pregnancy test. When you take one of those, it just says a yes or a no, or it says a positive or a negative. Those are the kind of tests we're talking about when we talk about CLIA wave tests, and it does not include like blood draws or something more invasive. The next thing is called standard of care. All healthcare professionals have to abide by this, and just pull the definition off of the internet. And the first thing about standard of care is that you're not providing any clinical services that are prohibited by state or federal law. The next thing is that you're only providing services that are within the individual's education, training, or experience. And then the third thing is performance of the act is with an accepted standard of care that would be provided in a similar setting by a reasonable and prudent individual with similar education, training, and experience. So if you get called in front of the board, you would have to prove those things on why you did that service. The next thing, Dr. Orentlicker did submit this. There are a couple amendments that we're proposing. The first one is on page 4, section 1. It changes have been previously diagnosed to do not require a new diagnosis. So on this, pharmacists would be able to prescribe medications and devices based on some things that were left out of the first definition, including epinephrine for allergies, immunizations, which we already can do under protocol, but it would just put this in statute. Contraceptives, once again, we could do that under statute. We can dispense contraceptives without a prescription, but this would just make the law clearer. And then the second amendment, we can also do a lot of things with lab work. When we sit down to assess a patient, we're always looking to see what ranges they're in and if their medicines need to be increased or decreased or discontinued. But right now in our law, it does not say we can interpret that lab work. So we're asking to put that in. So the substantive changes in this bill, in section 1, we would be able to prescribe for conditions that do not require a new diagnosis. So right now, pharmacists aren't being taught on how to diagnose patients in school, so we're going to leave that up to the physicians, the nurse practitioners, and the PAs. But in a lot of situations where a pharmacist is working inside of a medical clinic, they may be sitting down with that patient in 3 months or 6 months and going over all the patient information, such as what they were diagnosed with, their medications, their lab work. They're coming up with a plan. They're referring them out to other providers. But right now, we can't make changes to those actual medications, such as their dosage or changing the medication. So that's what that would do. The next one, we would be able to prescribe for conditions that are self-limiting. Right now, we do a lot of recommendations, assessing and recommendations of over-the-counter medications, but there are some conditions that actually need a prescription to get better. A case like this would be a pink eye, where an antibiotic eye drop would be required to prescribe. So types of things like that we would be able to prescribe for. C is we could prescribe for conditions that are diagnosed after performing a CLIA wave test. We've been doing this since the beginning of the pandemic. The PrEP Act by Congress allows us to actually do COVID-19 tests, and if that's positive, prescribe medications for COVID-19. The PrEP Act will be expiring, and we want to make sure that we are able to keep continuing to do those CLIA wave tests and getting patient the care they need. And also in this section, it would expand that to things like strep or flu or other things that CLIA wave tests are available for. D, in the professional judgment of a pharmacist, are emergencies that threaten the health of the patient. Once again, we were able to prescribe for emergencies throughout the pandemic by a order that was given by the Board of Pharmacy that has now expired. But a situation like this would be if a patient came into town and they forgot their medications and we weren't able to get a hold of their provider, but they had proof of what they were on, we would be able to prescribe those medications to get them through until they got home to get their medicines that they left back home. The good news is that inside AB 186, there's a lot of guardrails that are built in to make sure that pharmacists are actually doing the right things. The first one is that we could only prescribe drugs or devices that are approved by the FDA. And it also gives the Board of Pharmacy the ability to adopt regulations to make sure the things like what training the pharmacist would have to do, what's actual, if there's any protocols that need to be made. But the Board of Pharmacy is there to protect the patients in our state, so they would be making those regulations before we could do this. In Section 2, this just adds a couple things to the practice of pharmacy. So right now, we're able to administer drugs in a lot of situations, such as when a provider prescribes something on a prescription, we are able to take that prescription, and if the drug needs to be administered, we're able to do that. In last session, actually the 2021 session, there was a statute that passed that said that pharmacists could dispense hormonal contraceptives without a prescription. But unfortunately, in that case, we cannot administer those drugs if needed. So this would just include that. Also, we talked about we were able to do a lot of different things with lab work. Right now, we are able to actually perform laboratory tests for blood glucose and actually, give the patient their readings and refer them out. But we want to make sure that we can also order and interpret for those tests also. And then C is just going back to Section 1. Section 5, this has to do with lab work also. As I mentioned, pharmacists, they sit down with patients and they assess them and they actually go over lab work. But we want to make sure, well, right now we're not able to order that lab work. So if a pharmacist is working in a clinic, it's important that they can actually put orders out there to actually be able to take care of that patient and then interpret that. And then 5B is just that we would be able to perform those CLIA waive tests inside those pharmacies. Section 7, this would allow us to serve as an exempt director, or as the laboratory director of an exempt laboratory. The only reason why we're adding this in is because to do CLIA waive test inside of a pharmacy, a pharmacist has to register as a laboratory director of an exempt laboratory in order to do those CLIA waive tests. All right. So we heard earlier today that Nevada has a shortage of primary care professionals. Right now we rank 48th out of 50, and all 17 of our counties has a whole or partial shortage. And we do have over 2,700 pharmacists licensed here and living in Nevada. Since 2004, all pharmacists that graduate pharmacy school have to get their Doctor of Pharmacy degree in order to practice. That includes 6 to 8 years of education, at least 1,740 hours of clinical training when we're actually, it's a direct patient care where it's working directly with patients. And then we take our boards to make sure we're competent to practice as a pharmacist. And about 30% of pharmacists go on to additional training such as residencies, fellowships, or board certifications and specialize in different areas. You're probably thinking, how does pharmacy differ other than other medical professionals? Pharmacists use evidence-based medication and clinical guidelines just like the doctors, the nurses, the physician's assistants, the nurse practitioners. So we're going to be doing the same type of things when we're assessing the patients as they would. Also, when we're working inside clinics or hospitals or pharmacies, we're gaining experience depending on what we're actually doing. We will also be billing insurance companies for the clinical services. So we will have to make sure that we're contracting and credentialing and getting audited by insurance companies. And that's another guardrail to make sure that we're doing the things. What we've seen in other states, that even though statutes have guardrails and then the boards of pharmacy have guardrails, The individual companies are also making protocols, and they're determining what type of training the pharmacist would need and what they need to do actually to do those clinical services. And then, like I said, we must provide standard of care. We got to make sure that we're doing things which are best for the patients. And all this stuff includes collaboration with other healthcare professionals, including documentation of those services and referrals when needed. We keep hearing that it's unsafe, but if you do a search, we can't find any studies or reports that say pharmacists doing these types of services are unsafe. What we do find is a lot of studies that say the opposite. Right here, we're highlighting a meta-analysis that looks at 298 different studies that says using pharmacists as part of the healthcare team is a viable solution to improve U.S. healthcare. Also, there are studies out there that says that when a pharmacist is part of that team, they do save the health system money. And that can include making sure the patients are taking their medications right, making sure they're in the correct lab values, and that can reduce emergency room visits or other healthcare visits. Right now in Nevada, we can do a lot of different things, either through laws that have passed or federal laws that have passed. But the first one's medication therapy management. That's like sitting down with that patient and going over their whole background and making that plan and referring them out. In the last 2 sessions, you've also given us the ability to dispense those hormonal contraceptives without a prescription, assess patients and prescribe medications for HIV prevention, assess patients and provide medications for opioid use disorder. But unfortunately, there's some red boxes down here that AB 186 would help with. Right now, we cannot prescribe the drugs. So the pharmacists that work inside of a dispensing pharmacy can actually dispense the hormonal contraceptives without a prescription. But a pharmacist that actually works inside of a clinic or in a hospital, they can't actually prescribe a hormonal contraceptive. So it's just a little glitch in the law. The next one, for HIV prevention, we can't serve as that CLIA waive lab director. So it is happening throughout the states, but it's not happening. Basically, we're overriding the law with the PrEP Act right now, so we need to get that fixed. For opioid use disorder, we can't order urine drug screens. So just asking a patient to actually, urinate in a cup, according to our current law, we're not allowed to do that. But this law would fix that because it is part of standard of care and the guidelines. There's 2 other ones that just for time, I'm not going to talk about right now, but I will answer questions on if necessary. So we talked about these services are being done and they are safe. Since the 1960s, the clinical services have been done inside hospitals through protocols. In the early 2000s, the federal practice sites allow pharmacists to do these types of things through the VA health system and Indian Health Services. And then if you're wondering how many states actually have the authority for pharmacists to test and treat using CLIA waive tests, right now there's 16 states that allow that. And these states have almost all come about since the beginning of the pandemic because they saw that it was safe and that they want, when the PrEP Act expires, that they will still be able to do it. And as Dr. O said, that Colorado, Idaho, Iowa, Montana, they have the ability to do all the things we're asking, and then Idaho and Iowa actually have more things that than we're asking. I do have the references, but as you can see, this is being done throughout the United States and Nevada already. There's just some statutes that we need to fix, and we want to make sure that when the PrEP Act expires that we're able to continue doing this to take care of our patients. So I will pass it back to Dr. O.
Thank you, Ken. We have more experts, Liz Moyer from Albertsons and Liz McMenamin, but how are we doing on time for our presentation?
Are they presenting or just answering questions?
Well, I think each of them might have wanted to speak for a minute or two and then answer questions as well.
A minute or two is fine.
Good afternoon, Madam Chair, members of the committee. Liz McMenamin for the record. Just wanted to call say thank you to this committee for hearing this and to Dr. Warrenlicker for bringing it forward. We believe that at retail that these test and treat problems that we've had, as you know, many of you that have seen me before has known that I've been working on this for many years now to bring Nevada up to state and to fill a much needed void in our healthcare community. I would hope that people would be open to the changes, and going forward, we hope that this committee can see the importance of this. A recent poll showed that 78% of the adults in Nevada believe it's important for the state to update its policies to ensure that patients permanently have the same access to pharmacy vaccinations, testing, and treatment services that were available during COVID-19. 86% of the adults in Nevada say pharmacists are easy to access. And I want to emphasize it's an easy and safe access for patients many times when they can't get in to see their doctor for these simple tests, to have these done within the community pharmacy. We've been working on this for a long time, and I just ask that you consider this. We strongly urge your support on this so that those patients can receive the health care that they need. And I thank you for your time.
So I'll go ahead and go. Good afternoon, Madam Chair Marzola and committee members. For the record, my name is Liz Moyer, Lizmoir. I'm a pharmacist representing Albertsons Companies. I am the Director of Patient Care Services here. And I'd also like to note that I am a pharmacist practicing in the state of Idaho. Thank you for the opportunity to testify today in support of Assembly Bill 186. This bill will increase patient access to timely pharmacist treatment while maintaining high safety standards. So Albertsons Companies has 37 locations in the state of Nevada, operating under banners of Albertsons, Safeway, Save-On, and Vons. Nationwide, we have 1,726 pharmacies across 34 states in the District of Columbia. Our pharmacies provide critical support in Nevada's healthcare infrastructure, and in some cases are the only available access to a pharmacy in rural communities. Albertsons has successfully and safely implemented pharmacist prescribing across the country, with our pharmacists issuing over 1 million prescriptions annually across many drug categories and disease states while maintaining the highest standards of patient safety. Our real-world experience has shown pharmacists are critical first point of access for countless patients, many of whom do not have established primary care providers. Pharmacist prescribing has enhanced patient care, ensuring that individuals receive timely treatment for minor and chronic conditions. Our pharmacy locations serve as key referral hubs, directing patients with more complex medical needs to appropriate healthcare providers. And our approach strengthens the patient-centered medical home model. As a mother, my family's health is my top priority, and timely access to care can mean the difference between a manageable illness and a medical crisis. Long wait times at primary care offices, urgent care, and emergency rooms often leave us struggling to get the care we need when we need it most. Allowing pharmacists to prescribe medications for common conditions would provide a safe and convenient and immediate solution for families like mine. For busy parents juggling work, school, and family responsibilities, a pharmacy visit could mean getting a sick child the right medicine in minutes instead of hours or even days. Allowing pharmacists to prescribe for common ailments is not just a matter of convenience. It is a lifeline for families who need timely, affordable, and expert care. Assembly Bill 186 follows the success of Idaho, Colorado, Montana, and Iowa. This meaningful legislation that will increase patient access to timely treatment while maintaining high safety standards, providing a strong precedent for Nevada to follow. Thanks for the opportunity to speak today.
Good afternoon. For the record, my name is Adam Porath, Adamporath, and I am here today representing the Nevada Society of Health System Pharmacists. We're the organization that advocates for pharmacists and pharmacy technicians working in hospitals and health systems within the state. I've been a practicing pharmacist in Nevada since 2006. I've been working in direct patient care in a collaborative practice agreement in a clinic at Renown Health in Reno since about 2009. A lot of my testimony has already been gone over, so I just want to highlight that, a lot of progress has been made in the time that I've been practicing in this state. You know, fast forwarding to today, pharmacists can, through a collaborative practice agreement, see a patient in an office setting and help manage their chronic disease states like diabetes and high blood pressure. We can today independently prescribe medications to prevent HIV, treat opioid use disorder, and furnish oral contraceptives. I think AB 186 really builds on those past successes of increased utilization of pharmacists and takes advantage of their place in the community as the most accessible healthcare provider. The other thing that hasn't been touched on a lot is that this bill modernizes the language of the Pharmacy Practice Act to allow the Board of Pharmacy to establish the scope of this independent authority and establish that standard of care for pharmacist services in our state. This particular language will allow the practice of pharmacy to evolve with evolving advances of medical science and practice. I just really want to thank Assemblymember Orlinker for his forethought in introducing this bill, as I think it will truly help to advance and expand access to healthcare in our state. And I'm happy to answer any questions from you might have.
Ready for questions? We'll start with Assemblymember Miller.
Thank you so much for the presentation. Just trying to get a full understanding of what the scope would be. There's been some conversation about it wouldn't be about making a diagnosis. It would be for things that were more, I don't want to say chronic, but maybe consistent. And so I'm thinking, because my pause is, of course, that the pharmacist, as skilled and trained as they are, they don't know each individual's medical history, family history, the vitals, all those sorts of things. But I also know that there are some medications. I know myself, even when I was 7 years old and going through a lot of ear, nose, and throat issues, I would just go to my parents and say, I need some amoxicillin, right? Like I just knew that's what I needed. So is it for the scope of those types of things where even if it's not just your consistent, blood pressure or cholesterol medication, something like that. But even those, like amoxicillin, you need penicillin for a specific condition that, many parents and kids, we can kind of self-diagnose, and this is what's going on, and my kid needs amoxicillin. Would that be an example of what we're trying to achieve here? Because when I hear other things about the concerns, I'll just pause there and leave it there. Is that within the scope of what this bill is trying to achieve?
Assemblyman Orlicker, for the record, yes. This is for people who they've already been diagnosed, or we don't need, or the language says doesn't need a new diagnosis. Self-limiting, a minor condition. It's an emergency. It's the weekend, or maybe you've run out of your prescription. It's the weekend. Your doctor's office isn't going to answer the phone. This is not, now, you're going to hear, I understand from the opposition, well, cholesterol tests are one of those clear wave tests. This bill doesn't mean that you come in, they diagnose you with high cholesterol, and they're not going to start managing you chronically for coronary artery disease. That's not what this bill does, and one of the reasons why that's not going to happen is the section that says the Board of Pharmacy is going to implement regulations to flesh this out. If we just went by what's in the statute, I'm a licensed doctor. I can do anything with my license. I can do brain surgery with my license, but we don't use the statutes to go into the kind of detail because there are other regulatory mechanisms to make sure that David Orlicker is not doing brain surgery tomorrow.
That last statement made me feel a lot more comfortable as well. Thank you for that. Thank you, Chair.
Vice Chair Howdigi.
Thank you, Madam Chair. And I have a couple of questions, if that's okay. My first one is, can you just give us an example of a time when a pharmacist can reissue a prescription without issuing a new diagnosis? Give us an example, like just one example.
Ken, you want to step in?
It looks like Liz is she's the one who does it on a regular basis, so I'll let her, Liz Moyer.
Liz Moyer for the record. So I have actually a few examples of how we do this. We actually offer like 29 different services in the state of Idaho. So think about things like cold sores. That's one of the first ones that we started with in 2018. So somebody has had a cold sore in the past. They don't have a current prescription for it, right? So they come in, they know they have a cold sore. They've been diagnosed in the past. Maybe it's been 5 years, their medication's expired. We do a very thorough screening for that. So we get their medical history, any medications that they've been doing. Our pharmacists have additional training on what does a cold sore look like? What's the differential kind of prospects, but we don't need it as much because that person knows that they've had cold sores in the past. So that's one really good example of they may need an oral antiviral to treat that. That's not available over the counter, or they may need a topical antiviral. So that's kind of one of the ones that we look at. There's another one, urinary tract infections we do in Idaho, because if you look at the guidelines say most women, if you've had one before, you know what it feels like. And so we do any lab work that needs to be done or blood pressure or any of that. It's just the same as if you were going into a physician's office. There could be a urinalysis if you need one that they do in the restroom. So there's a lot of different things that can be done to help provide that care that we're looking at. It's like minor and self-limiting in nature that doesn't require a new diagnosis. So does that help answer the question?
Yes, it did. Thank you. I just wanted to put on the record the kind of examples like how a family would be able to use this. I like that a family might not have to take time off during the day and pull a child out of school to go go see their doctor and wait there for hours to get a new prescription for a cold sore, right? They could do it after they get out of work at 5 p.m. Like, I like that, especially increasing the access to families throughout Nevada, because we do have a problem with access to healthcare here in Nevada. But I do want to ask, I mean, what's the capacity of pharmacists in Nevada to be able to handle this? Like, if this bill passes, do we have enough pharmacists in Nevada to handle these requests that would be coming into their offices every day? Or would that increased workload hurt them in any way?
I can answer. I can try to answer that. So Ken Kunke for the record. When these laws pass, it's a slow burn as how they roll out. We saw in Ohio when they actually were able to start billing for clinical services, only about half a percent of pharmacists actually billed for clinical services the first year that they rolled out, and in the second year was 1% of those pharmacists. Each company is going to have to determine their capacity to be able to do these services, such as Albertson, CVS, those type of things. But we do see them rolling out slower rather than faster, just because they want to make sure it's safe and everybody's trained.
Thank you, Madam Chair. I promised my last question. Thank you. And so I didn't see that in the language, and maybe you can point me to the right direction if I just overlooked it, but I saw the board may adopt regulations. I didn't see that the board would be required to adopt regulations for this. So if this bill passes, would pharmacists automatically be able to start practicing in this way, or would there be a requirement for the board to come up with regulations? And could you walk us through a timeline to implementation? Like, if this bill passes, what is that timeline to implementation?
Dave Weiss for the record, the Executive Secretary of the Board of Pharmacy. I'm neutral on the bill, but I was asked to be here for questions. May was my request, just because if there was no opportunity to do anything, then I have to do regs when there's nothing to do. But I think the board would be doing regulations. We've done that through everything else that you've given us. They've already mentioned all the different categories where pharmacists can dispense and prescribe. So I think we will. I think there's some really low-hanging fruit, so we're listening to you on what would be the first things that we would tackle. But I think there are patients that would want to go to the pharmacy and be able to get a prescription at that time. And I think, to your point, they're getting the questions now. They just can't do anything about it.
And just that last part of my question, the timeline to implementation, like if this bill passes, like when would
6 months would be a typical time frame if everything goes, and I'll again point out that nothing would move forward without legislative commission on regulations approving it, so it's not like the board would do it and then the legislature would lose control of what's happening.
Please remember to state your name for the record. We will go next to Assemblymember Hardy.
Thank you, Chair. You know, I think most of us have had those late nights and things where we go to the pharmacy and for a child or ourselves and ask them, you know, I'm not feeling well, can you recommend something for me? So I understand that, and I'm getting a better grasp of what the CLIA wave tests are and what they could actually prescribe for self-limiting conditions and things like that. I just have a question thinking through this. So what if they come in and they have a certain condition and then that worsens, and you could have like a symptom that maybe you think is a cold or flu, but it's actually indicative of something more? And I'm especially thinking like maybe for children or older people. And then is there any like requirement, or do they do this already? Like they need to contact a physician, you know, if it's getting worse, so there's more symptoms developing?
Adam Porth for the record. Yes, I think that goes back to what is the standard of care. So that if you're going to be testing for strep throat and you're going to be providing treatment for that, if there's an indication that it is beyond the scope and that needs to be referred to a higher level of care, that is absolutely within this. So, you know, you're not going to be able to do that simply with this CLIA wave test. You would have to be able to actually take a blood pressure and see what's going on there. So yeah, if there are indications that this is something that is worsening or an infection that maybe can't be treated in an outpatient setting, that would be part of the process that the pharmacist would need to refer a patient.
Assemblymember Cole.
Thank you very much. So my question, and I actually kind of have two questions, so I'll ask the first one and then ask permission. So when we're talking about in the professional judgment of the pharmacist are emergencies that threaten the health of the patient. So Assemblymember, you gave an example of something that seems to make a lot of sense. Somebody's on vacation, they forgot their meds, get them a prescription. But I think this language needs to be tightened up significantly, because I think what could also fall into that is somebody in a mental health crisis moment, and I wouldn't want pharmacists to be able to prescribe some kind of a drug like a Thorazine or Sterazine or something that would be very, very strong. So I think that language needs to be tightened up.
Assemblymember Orient-Lecker, for the record, happy to work with you on getting the language right.
Thank you very much. My other question is too, and you probably won't have this information with you, but I look at it from the perspective of whatever malpractice insurance these pharmacists have to carry now, and what the implication could be for their malpractice premiums to go up significantly because the scope of practice is being expanded so much. So perhaps from the other states, you might have that information.
Dave Weiss for the record, I'll comment on it. There's other components in the law that require certain malpractice when they're doing certain things, so that's something that could be layered into the regulations. I think the vast majority of pharmacists do carry malpractice insurance, but to your point, it's much different than what a physician's carrying. So I think I think your point is right. As any practitioners, and we've seen this with all the different prescribing practitioners, we had three at the last session that gained prescribing rights. That's obviously something that they should be aware of.
Assemblymember Monroe Moreno.
Thank you, Chair. I think my question is going to be for Ms. Moyer. You're in Idaho, correct?
Yes.
So my question is, how is this working with the insurance companies in your state? When the client comes in for the diagnosis, is that considered like a clinical visit on the insurance or urgent care visit? How's that billing working for that visit to get the diagnosis for the prescription?
Liz Moyer for the record. So billing is a challenge, right? So medical billing is finally starting to take off. In the state of Idaho, we've been recognized by our blues as providers. So we are able to bill for a certain level of care, right? So depending on the service, we might do a pulse ox, we might do a blood pressure, we might do all of them. But it's basically a new patient visit and then potentially an existing patient visit. So we have coding that's associated with the visit types. And then we can also bill separately for the test itself. So if I do a visit for a new patient for strep, and then I bill a separate claim for the patient for that strep test. But primarily, and we see this mostly across all of our states that do different types of prescribing, much of it is a cash pay business. So we have a cash fee, a fee for service scale that we do for people that are not insured. So for example, if you came to Idaho and you didn't have any insurance and you wanted to be seen for a UTI, that you would pay $35 for the visit and then the price of the prescription. So it's not quite in line with what would be the standard of care for the level of care we're providing, but the goal is to expand access to healthcare and make it affordable.
Thank you, Madam Chair. And for those that do utilize their insurance, is it considered an in-network charge or an out-of-network charge for the patient?
So we're contracted with them in Idaho, so it's in-network.
Thank you. Thank you, Madam Chair.
Committee members, any additional questions? I don't see any. I did have a, oh, go ahead.
Hi, thank you. Thank you for their presentation. I'm definitely interested by this idea. I'm wondering like what procedures would be put in place, or what procedures maybe are put in place in other states to prevent maybe individuals from like, I just see like a lot of situations in which like a person their doctor says, okay, you need to stop taking this medication. This person likes taking that medication. They don't want to switch for whatever reason, and so they're just going to go see a different provider. And so I just like a little bit of concerns. And I'll be honest, there are prescriptions that are given over the counter, and I don't know. Like when I go in to get my Sudafed, it's very quick. They scan my ID and they give it to me, right? Like, so what type of care, I guess, what does this quality of care look like for the patient? For example, if somebody has a UTI and they've had a UTI for a while, they shouldn't just be coming into the pharmacy, getting the medication, coming back in 2 weeks, getting the medication again. It doesn't address, there's something else going on, right? So how would that be addressed?
Dave Weiss for the record of the board. How it's currently done, to your point, with the Sudafed, there's a system in the background that's checking all the Sudafed, so we know if you go to multiple pharmacies for the Sudafed. As it relates to those prescriptions, I think that's under the professionalism of a pharmacist. So like Adam was saying, that if it's escalating or it's not resolving, that there's going to be a referral out to a doctor or go see your doctor. As it relates to the pharmacist and their intention between dispensing and prescribing, we already have over 1,000 practitioners in the state that dispense along with prescribing. So I think that's naturally, I think it's safe. I think when you bring the drugs as close to the patients as you can, that's for the best. So I think that the pharmacist would use their judgment. And that said, that same thing, and I think it's a valid point, that same patient could do that currently, not so much with the opioids, because we've addressed those things, but with just the dangerous drugs, they could go to multiple places.
Committee members, any additional questions? I don't see any. I had a question about capacity, which you answered. My last question is, I know that you're wanting authority to prescribe, but we are not in any way talking about any sort of controlled substance, correct? Or any sort of opioids?
Dave Weiss for the record, as it states, this would not prohibit it. So that might be something that Assemblyman would work on to resolve that. That said, pharmacists currently can prescribe, and we're working through the DEA with the final level of that, to treat opioid disorder. So there are pharmacists that would be able to prescribe opioids in that circumstances, but a limited amount for the treatment of opioid disorder, not for pain and those kinds of things.
Correct. So that was my question. I know they can prescribe right now for the disorder itself, but so when we're talking about painkillers and things like that.
Dave Weiss for the record, that may be something that we have to do with an amendment if they choose to do that, because emergencies and pain may go together. So that might be something that you would want to limit with the bill.
Does anyone else want to answer my question? Is that what you're asking for in this bill, is to be able to prescribe controlled substance, opioids, things like that as well?
Ken Kunke for the record. Yes, in the other states, controlled substances are allowed, those 4 states that we were that we mentioned. The reason why is because pharmacists do additional trainings. And so a pharmacist that's working in a clinic that needs to prescribe pain medications in certain reasons, they would be allowed to, but they still have to practice standard of care, and they would have to do everything another provider would have to do before prescribing those controlled substances.
Thank you for that response, and we can chat more offline. My last question is on your PowerPoint. When you talk about travel medication, believe it's page 3, can you give me some examples of what you mean by travel medications?
Adam Porth for the record. So there's a lot of pharmacies that offer travel vaccines currently. And so in addition to that, oftentimes, depending on where you're going, you might want to have a prophylactic prescription, antibiotic prescription for diarrhea. And so this would allow the pharmacist to be able to prescribe those prophylactic antibiotics.
Great, thank you. Last chance, members, any questions? I don't see any. So if you guys can move for a little while so I can take some testimony in support to Assembly Bill 186. Is there anyone here in Carson City wishing to testify in support?
Matt Robinson with our Genum Partners, here today on behalf of the Southern Nevada Health District, and more specifically the Southern Nevada Community Health Center. As a FQHC, we provide primary healthcare services to underserved Nevadans in our community. Pharmacists are a key part of the healthcare team and support services that create access to care. We encourage the committee to support AB 186 to enhance the scope of practice of pharmacists, to supplement the practice of other providers and increase access to essential medical care for Nevadans. It supports our health center in 3 key ways. Expands access to care, removes barriers to accessing essential medications, and supports the practice of other providers in the community. Once again, we urge the committee to support AB 186, which will further enhance our ability to provide care for the most vulnerable Nevadans. Thank you.
Thank you. Is there anyone else in Carson City wishing to testify in support? I don't see anyone in Las Vegas broadcast. Is there anyone on the line?
Testify in support of Assembly Bill 186. Please press star 9 or raise your hand in the Zoom window to take your place in the queue. Again, if you wish to testify in support, please press star 9 or raise your hand in the Zoom window.
Hello all, my name is Dr. Amy Hale. I'm a licensed pharmacist in the state of Nevada and I support this bill. I'm also licensed as an RN in Nevada and started my healthcare career as an EMT 19 years ago. I've always served in a direct patient care role until 2022. I am board certified and residency trained, but became frustrated at the continued barriers to care as I, a pharmacist, encountered, despite the fact that I had 97% of my recommendations accepted by the 9 physicians I worked with in their oncology practice in Las Vegas over the 3-year period that I was there. Please remember that a large number of us do not work in a typical retail pharmacy setting. I left that position for the pharmaceutical industry, and my story is not unique. I know literally a dozen other pharmacists who are trying to or have replicated this path for these exact reasons. I urge you to consider passage of this bill to keep our qualified, dedicated pharmacists in direct patient care here in Nevada for better outcomes and higher quality and less expensive care for our residents. Thank you.
Caller with the last 3 digits, 183, you are unmuted. Please check if you are unmuted on your end and you may begin.
Hello, my name is Zach Roscoe, Zachrosko. I'm a licensed pharmacist in Las Vegas and have been here since 2022. I just wanted to support or encourage you to support AB 186 for all of the reasons that have been stated by other presenters today. I also wanted to add that I am also licensed and have practiced in Idaho, another state with more expansive scope than we are asking for here today. And just wanted to say that I have directly seen the impact this can make on both care team-based delivery and partnering with other providers and in our patients' lives. Thank you for your time.
Good afternoon. My name is Evan Williams. I'm a pharmacist in Henderson, Nevada. I've been a pharmacist in Nevada since 2016. And I want to just say that I urge the committee to support this bill. I've been practicing for quite a while. I'm residency trained, board certified, and I've practiced under much more expanded scope within the federal system as a commissioned officer at the VA, with the Indian Health Services as well. And I've seen firsthand the impact that this type of scope expansion can have by not limiting pharmacists to kind of what people might think is more traditional roles. We've definitely expanded access to care in all of these settings. And I see a great opportunity here to try to expand this further for the people of Nevada. So again, I urge the committee members to support this bill. Thank you.
Hi, my name is Natochi Adeolokun, Adeolokun. I'm a pharmacist in Reno, Nevada. I work at a federally qualified health center and work collaboratively with all of our medical providers who utilize this skill set of a pharmacist. So I please encourage everyone to support Assembly Bill 186 to expand the services and open up more care for our patients in Nevada. Thank you for your time.
Good afternoon. My name is Kelsey Maxim, M-A-X-I-M, and I am a licensed pharmacist in Nevada. I'm the Director of Retail Pharmacy at Community Health Alliance in Reno, Nevada. I urge the committee to support Assembly Bill 186 to expand pharmacists' scope of practice. As previously discussed today, I fully agree that this bill will expand access to health care, improve patient outcomes, and many other direct benefits to our patients. I appreciate your time.
Tom, T-O-M, McCoy, M-C-C-O-Y, Nevada Chronic Care Collaborative, where our mission priority is access to care. Here's my 5 takeaways of why AB 186 will benefit Nevada patients. Many Nevadans face access to care barriers. Under AB 186, we heard that pharmacists could prescribe medications for minor conditions and do simple lab tests. Number 2, pharmacists are highly trained healthcare professionals that right now are underutilized. They can help with our shortages in primary care providers. Number 3, pharmacists are medication experts who can provide ongoing chronic conditions care, resulting in better medication adherence and improved long-term health management. Number 4, pharmacists provide care offers a convenient and cost-effective alternative to ER visits, thus addressing health disparities in our state. And number 5, patient safety, quality of care is ensured by 186 defined regulatory framework that we heard about, and importantly, there's going to be oversight by the Nevada State Board of Pharmacy. With passage of AB 186, more timely access to care and reduction of strain on our overburdened healthcare system. AB 186 can't solve all the access to care problems, but it sure could help. Thank you.
Hello, my name is Jeannie Smith. I am the Chief Pharmacy Officer at Nevada Health Centers, a federally qualified health center serving patients across Nevada, including in rural and medically underserved communities. I'm also a clinical pharmacist who provides direct patient care. I strongly support AB 186 because it directly addresses healthcare access gaps that our patients face daily. In our FQHCs, we serve patients who often wait weeks or even months to see a primary care provider. Pharmacists are highly trained healthcare professionals who already are embedded in these communities, manage chronic conditions, and provide essential preventative care and also reduce ER visits. Allowing pharmacists to prescribe for minor and self-limiting conditions means faster and more affordable care for patients who struggle with transportation, lack of insurance, or need timely treatment. It's not about replacing providers, but enhancing team-based care and using every resource available to us to meet the needs of Nevada's most vulnerable patients. I urge you to pass AB 186, and thank you for your time.
Hello there. My name is Jonathan Wolfson, for the record, W-O-L-F-S-O-N, and I'm Chief Legal Officer and Policy Director at the Cicero Institute. We're a public policy think tank that works on access to care issues and other issues across the country, and we are here in support of the bill. We believe that this bill is one way to address Nevada's physician shortage, and one thing I've had the privilege of working alongside pharmacists who are in the academy for a number of years. And when I began working with them a decade ago, I was not aware of how much clinical training pharmacists had. And I had kind of the stereotypical understanding of what pharmacists did and what they were trained to do. But now that I fully understand the number of hours of training, in fact, over 1,700 hours of clinical training, which is more than double what a lot of other folks with full practice authority and full authority to write prescriptions have, it makes a lot of sense to give expanded scope of practice and allow pharmacists the opportunity to practice and serve those patients. And for all those parents who are struggling to try to find care in the middle of the week when they're trying to be at work and they have kids who are sick, pharmacies tend to be open on those weekends. And so we support this legislation, and we appreciate the sponsor for bringing it. Thank you.
Chair, there are no more callers choosing to testify in support at this time.
Thank you. We will move to testimony in opposition to Assembly Bill 186. Is there anyone here in Carson City wishing to testify in opposition? Please remember to state and spell your name for the record. You each have 2 minutes. You may begin when you're ready.
Thank you, Chair Marzola and members of this committee. Leah Cartwright, Leacartwright, here today on behalf of the Nevada Psychiatric Association. The committee has pointed out several areas of the bill of concern, and you'll hear more from the House of Medicine later on from NSMA. I would just like to point out on the CLIA wave test list, if you read through, there's a little over 1,400 of them. I wanted to point out some of the tests that are included that have impact on psychiatry. These include lithium, your lithium levels, tricyclic antidepressants, benzodiazepines, amphetamine, methadone, buprenorphine, methamphetamine, fentanyl, norfentanyl, oxycodone, ethanol, salvia alcohol, cannabinoids, phencyclidine, barbiturates, and morphine. So there are a couple of those tests on that. It's a big list. I've learned more about CLIA wave tests in the past 12 months than I ever needed to, not having gone to medical school. So again, the Nevada Psychiatric Association, along with the House of Medicine, has several concerns about these bills, or this bill. It would take a long time to list them out in their entirety. I don't have more than 2 minutes, so I'll pass it on to my colleagues, and I believe there are some physicians on the line.
Good afternoon, Madam Chair and members of the committee. My name is Sarah Adler with Silver State Government Relations, and I represent the Nevada section of the American College of Obstetricians and Gynecologists, who really appreciate the effort to increase access to health care, but do stand in opposition to AB 186. In the words of Dr. Sandra Koch, pharmacists are simply not trained to treat chronic disease. Now, ACOG would note that they appreciate the ability for pharmacists to dispense contraceptives, and that was put specifically into law because that was an appropriate matchup of a need and a skill set. I also happen to represent the Nevada Opioid Treatment Association, and NOTA did not object to pharmacists becoming able to dispense buprenorphine and Suboxone because in rural Nevada we just don't have access to that treatment in the way that an OTP can provide it in an urban area. But again, to repeat, ACOG opposes AB 186. Thank you.
Thank you. Is there anyone else in Carson City wishing to oppose Assembly Bill 186? I see someone in Las Vegas. If you're there for opposition, please remember to state and spell your name for the record. You may begin when you're ready.
Thank you so much. Good afternoon, Chair Marzola, Vice Chair Hadegui, and members of the Assembly Commerce and Labor Committee. My name is Jacqueline Nguyen, Nguyen, and I represent the Nevada State Medical Association, who is in strong opposition to AB 186. Increasing access to care is a priority in Nevada, but this bill is not the way to do it. First, there is a valid concern that AB 186 could inadvertently place profit motives above patient care by allowing pharmacists to perform the test, diagnose the medical condition, prescribe the treatment, and then sell the medications. This may lead to corporate pressures on pharmacists that may harm patient well-being. But most importantly, this bill illustrates that it's not always the case that some care is better than no care. This bill can have devastating consequences to the health of patients. The list of CLIA wave tests is extensive, some of which are complex. While pregnancy and COVID-19 tests may be straightforward, the list also includes complete chemistry panels, lipid profiles, thyroid tests, and glucose monitoring, including A1Cs. Without adequate clinical training, pharmacists may not be equipped to properly diagnose and treat conditions linked to some of these tests. I have multiple examples from my doctors, but I only have 2 minutes, so I'll give you a straightforward one. If a patient develops worsening fatigue, altered bowel habits, and mildly elevated heart rate since their last doctor's visit, a simple CLIA wave hemoglobin test by a pharmacist might not capture the underlying issue. In this case, while the test result may remain unchanged, a physician would consider the possibility of other serious conditions, such as a gastrointestinal bleed or cancer, which would necessitate a change in the treatment approach. Without the benefit of a physical exam and a full medical history, the pharmacist may miss these critical signs, leading to a misdiagnosis of continued iron deficiency anemia when the patient is actually experiencing an acute and potentially life-threatening condition. My physicians are concerned that this bill, which permits pharmacists to order tests and prescribe treatment for established conditions without conducting a comprehensive physical exam or reviewing and understanding the patient's medical history, may compromise the quality of care for patients because the CLIA guidelines are so broad. Passage of this bill creates confusion as to who is responsible for patient care. Pharmacists are not trained in clinical medicine, nor do they establish that long-term care relationship. Will pharmacists have to keep charts on patients and make referrals to specialists? Will they be available for call and follow-up care? While this bill wants you to categorize pharmacists performing these tests as the practice of pharmacy, it's clear that it can be the practice of medicine. We must ensure that the quality of care for patients remains our top priority.
I hate to interrupt you. Can you finalize your statement, please?
Of course. We must ensure that the quality of care for patients remains a top priority, and it is for these reasons that we're in opposition. Thank you.
Thank you so much for your statement. Is there anyone else in Las Vegas? I don't see any broadcasts. Is there anyone on the line wanting to testify in opposition?
To testify in opposition to Assembly Bill 186, please raise your hand in the Zoom window to take your place in the queue.
Good afternoon, Chair Marzola and members of the Assembly Commerce and Labor Committee. My name is Nehal Naik, that's Nehal-Naik. I'm board certified emergency physician and a member of NSMA, and I serve patients throughout the Las Vegas area valley. I'm here to oppose AB 186. I respect the valuable role pharmacists play in our healthcare system. I work closely with them as partners in the emergency department, but this bill raises serious concerns. Big thing is Section 1D allows the pharmacist to determine if there's an emergency that threatens the health of the patient. This seems especially egregious. I'm an emergency physician. Everyone I see in the emergency department is there for an acute condition. I need to ensure that someone's chief complaint does not show signs of serious illness. And if it does, I address it. How are pharmacists trained in addressing emergencies? Are they providing the similar medical screening exam that I'm required to do by federal EMTALA regulations? No, they're not. Let's take that simple strep test. When I see someone with a strep throat, I need to examine the patient to make sure they don't have a life-threatening illness, which may occur from a simple strep throat. This includes things like peritonsillar abscesses, retroperitoneal abscesses, loading angina. A lot of jargon, I know, but these can all rapidly progress into an airway emergency requiring intervention, even for UTIs. If someone comes with just pained urination, I need to make sure it's nothing life-threatening, like a kidney infection or pyelonephritis, which simply add on the symptoms of back pain. I also look at antibiograms locally, resistance patterns, look at prior urine cultures to see if they've grown drug-resistant bacteria. Can the pharmacist do this? So if a pharmacist is able to perform a strep or urine test, are they evaluating the patient with a full history and physical, assessing medical history and risk factors? That's what the practice of medicine is. Finally, this legislation could exacerbate healthcare disparities. People in underserved communities with limited access to physicians may start relying on pharmacists for diagnosis. For this, I urge you to prioritize patient safety and the integrity of medical practice and oppose this bill. Thank you for your time and consideration.
Chair, there are no more callers to testify in opposition at this time.
Thank you. We will move to neutral testimony. Is there anyone here in Carson City wishing to testify in neutral? Please remember to state and spell your name for the record.
Good afternoon, Chair Marzola and Committee. Shelley Capurro, SHELLYCAPURRO, for the record representing the Nevada Association of Health Plans. And we want to thank you for being able to comment. Some of your questions and the conversation is what we're hoping to work towards with the sponsor of this bill. We have administrative and member care issues that we're going to be discussing. Proper medical records documenting previously diagnosed health conditions must be available and reviewed prior to pharmacists prescribing and providing treatment. This is especially important for health conditions that require treatment and management by specialists. We also recommend that the legislation be explicit that if providing medical care and treatment to a Nevadan, a patient-pharmacist relationship is created similar to that of a doctor-patient relationship, especially if the member's health condition requires routine follow-up and continued management and care. Finally, that the legislation includes a provision that establishes and outlines the process necessary for pharmacists to submit claims for medical benefit reimbursements. This is especially important since pharmacy benefits and medical benefits are distinct. Thank you.
Thank you. Is there anyone else wishing to testify in neutral in Carson City? Go ahead, you can come up. Remember to state and spell your name for the record. You have 2 minutes. Can you turn on your mic?
Thank you. Good afternoon, Chair Marzola and members of the committee. My name is Grace Larkins, that's Larkins, and I am both a parent and an advocate for individuals with complex medical needs. Today, I want to introduce a perspective that may be overlooked because the population is small but has an incredibly high need. Nevadans with complex medical conditions who depend on durable medical equipment, or DME, for daily survival. I'm the mother of a 10-year-old daughter, Lucy, who has a rare genetic disorder, cerebral palsy, and epilepsy. For the past 18 months, I've been working as part of a statewide DME work group focused on improving the cumbersome process of acquiring necessary equipment, such as wheelchairs, incontinence supplies, and feeding tube supplies. Delays and denials are unfortunately the norm. For example, it took over 4 months to get the new size up of the same diapers for my daughter as she's been wearing for years. It took us a year and a half to get her wheelchair. A teenager in our network needed a simple size adjustment for their walker and had to negotiate numerous appointments and paperwork, waiting almost an entire year. DME fulfillment often gets caught in procedural loops, creating unnecessary delays and additional costs for taxpayers. These challenges harm patients and place an unavoidable strain and cost on the healthcare system. Last year, our work group discovered that DME providers in Nevada are licensed under the Board of Pharmacy. AB 186 is a smart solution to help unclog the broken system and alleviate some of this backlog by allowing pharmacists to authorize routine DME orders, such as size adjustments or for incontinence supplies or replacement parts for mobility equipment. This could help reduce delays and allow specialists to focus on the more complex medical needs. For individuals with permanent conditions such as cerebral palsy or spinal cord injuries, requiring new authorizations for every supply is burdensome. Streamlining DME access through thoughtful prescribing policies would reduce delays, improve health outcomes, lower costs, especially in light of the workforce shortages that families like mine feel very deeply every day. If this bill moves forward, I urge you to consider durable medical equipment in the future discussions. I think it may be a smart solution. It's critical that these are addressed in a comprehensive way to meet the demands of Nevadans with long-term complex medical needs. I thank you for your time and consideration.
Thank you. Is there anyone else wishing to testify in neutral? I don't see any. I still don't see anyone in Las Vegas broadcast. Is there anyone on the line?
Chair, there are no callers to testify in neutral at this time.
Thank you. Assemblymember, would you like to give any closing remarks?
Yes, Assemblymember Ornlicker, thank you very much for your consideration. Of course, I'm happy to work to make sure we draw the proper lines and have the right guardrails in place. I'll just say, take you back. Remember, we have states that are doing this already, states that have gone beyond this. In all the opposition testimony, you heard hypotheticals that sounded like a Stephen King novel, but you didn't hear anything in terms of data or studies that have found any of the concerns that they raised. The studies all show that this can be done and is being done in a safe way to increase access and bring down costs of health care. So thank you.
Thank you. I will now close the hearing on Assembly Bill 186. I will now open the hearing on Assembly Bill 207. This measure revises provisions governing the submission of certain information to the Commissioner of Insurance relating to mental health parity in addiction equity. You guys may begin when you're ready.
Hello. This is my first time sitting on this side of the dais, so I appreciate this.
Do you have your microphone on?
Oh, I do, yes.
Oh, okay.
Can you hear me? Oh, is that better? Good afternoon, Chair and members of the committee. Thank you very much for allowing me to be here. My name is Lisa Cole, and I am the proud Assemblywoman for District 4 in Las Vegas. I'm honored to be accompanied by Spencer Flanders and Dr. Lori Drucker to help me present this important bill. Mental health impacts every family, every community, and every corner of our state. It does not discriminate by age, income, or political affiliation. It affects hardworking Nevadans who simply want to live productive, fulfilling lives. Yet many of these people are being denied the care they are rightfully entitled under the law. This isn't about expanding government or increasing spending. It's about ensuring fairness and accountability in a system that is already in place. We have laws on the books that guarantee mental health parity, but without transparency, those laws are meaningless. If insurance companies are denying legitimate claims, we need to understand the reasons so we can address them. We believe in personal responsibility, and we know that when a person reaches out to a mental health practitioner, they need help, often immediate help. And any barrier to receiving that help can be devastating. Hardworking Nevadans who are covered by health insurance should receive the care they need, and if a claim is denied, it's imperative we understand the why. This is about transparency, about making our systems work as they are intended, and it's about giving Nevadans the tools they need to make informed decisions for themselves and their families. I sit here today not asking for more regulation, but for fairness, clarity, and accountability, because every Nevadan deserves to know that when they need help, the safety net that they've paid for will be there. We have been presented with an amendment. I don't believe that it is in front of you at the moment, but we are working right now on that language to address the concerns regarding trade secrets. Right now, we feel that the amendment is a bit too broad, but we do understand the spirit of their proposed amendment, and we're working with them to address the stakeholders' needs and issues. Chair Marzullo, with your permission, I would like to pass off the presentation now to Spencer Flanders, who will give us details and background on this bill. Thank you.
Thank you, Assemblymember Cole, and good afternoon, Chair Marzola and members of the committee. My name is Spencer Flanders, for the record. That is spelled S-P-E-N-C-E-R-F-L-A-N-D-E-R-S. I am with Tri-Strategies, and I'm super excited to be here on behalf of the Nevada Psychological Association today to discuss Assembly Bill 207, which deals with mental health parity. I do have a presentation, but I do not see it currently up. Nope, it's not on here, but that's okay. We can keep going through. So some of you may be asking, what is mental health parity? And the most simple terms for this is making sure we take mental health care as same as physical health care. We must treat them the same. And this is not just me saying this. This is actually put inside federal law in the Paul Wellstone and Pete Dominguez Mental Health Parity and Addiction Equality Act of 2008. Quoting right from this act, it says, the treatment limitation applicable to such mental health care or substance use disorder benefits are no more restrictive than predominant treatment limitations applied to substantially all medical and surgical benefits covered by this plan. And what this essentially does is put mental health parity inside of the law. So there's a second part to this act, and specifically this deals with reporting. So I'm going to go into the details there. So the first part in the reporting of mental health parity is a disclosure of medical necessary criteria. When you get your medical benefits, you get an EOB, the explanation of your benefits. And it's going to say, oh, you have this amount of doctor's appointments, this amount of physical therapy appointments, this amount of this and that. So say we had physical therapy appointments and you had 20 covered, you would need a matching for mental health appointments as well, according to this federal law. In addition to this, you also have the explanations for your denial of mental health claims, which needs to be reported. So any denial of mental health claims gets to report right to the Division of Insurance. What's super interesting is that states actually get the ability to enforce this, and it also has oversight with the federal government. So going right into how the federal government gets their information is through the system of electronic rate and form filing called the SIRF. This is developed by the National Association of Insurance Commissioners, and it was required by the federal government for insurance companies. It collects information on denial claims and compliance review. Now, so what does the SIRF actually do? It collects denial justification, medical necessary criteria, which is those EOBs we were talking about, appeal information, that's any information between insurance and policyholders, regulatory compliance with the Mental Health Parity Act, and then it gets everything and puts it in statistical data points. We'll keep going through. Next page. There we go. Lost my place there. There's many different states that use the CERF for mental health parity. We have California, Oregon, New York, Washington, Massachusetts. We have Tennessee, Ohio, and Arizona that all use the CERF. And I think what's very, very clear too is every insurance company has to use CERF for federal reporting. They don't always have to do it for state reporting, but they use the system in those ways, and it's also used through many different insurance claims. So it's a unified system that's really very easy to use. So the current issue in Nevada is that we do not use CERF. We do not use that system tracking system. What we do is just collect the information through various different forms, which makes it hard to put it into a consolidated area and actually look what's going on. And as much as I would love to help the Division of Insurance with administrative work, our main claim today is that we want to have transparency of the Mental Health Parity Act. When the Nevada Psychological Association approached the Division of Insurance to get information, we were denied access. This is super important because we're hearing psychologists say that their claims are getting denied, they don't know the reasonings for this, and we want to have some more transparency there. And the whole purpose of having this act is to have the transparency, to make sure that we are treating mental health care the same as physical health care. Now, psychologists better than anybody know the importance of making sure that their information is being confidential. And we have claims inside of our bill, which specifically look at making sure we have personally identifiable information being not discussed and not being shared to public record. To discuss this a little more, I would love to pass it off to Dr. Lori Drucker, who actually works in psychology, and I'm going to pass the microphone off to her. Thank you.
Thank you, Madam Chair and members of the committee, for this opportunity to speak with you. Much easier for me to be one-on-one in my office than facing all of you, so I'm going to apologize for the nerves to start off with. Dr. Lori Drucker, L-A-U-R-I-E-D-R-U-C-K-E-R. I am a psychologist here in Nevada. I'm also here on behalf of the Nevada Psychological Association. We're asking for your support for this bill as part of Nevada's commitment to improving access to care, an issue that I know you're hearing about over and over again. Reinforcing mental health parity is vital for allowing individuals to access needed benefits under their insurance plans. I was a provider in 2008 when MAPIA, which is our easy way of saying the Mental Health Parity Act, was passed. Previous limitations on the number of visits, which were often 10 to 12 per calendar year for every mental health diagnosis, were eliminated. Co-payments dropped to the same level as those for primary care services, and patients who needed to access their out-of-network benefits could afford to do so. Recently, I have had to ask for prior authorization for a client to access their out-of-network benefits with a deductible so high that the insurance company was never going to pay anything towards their treatment. Other insurers are limiting the number of visits again. I've gone back to 12 sessions per calendar year and then have to ask for authorization for more. Understanding what is covered and for how much is often confusing for myself and my clients, and many of my clients pay substantial sums of money out of pocket before their benefits kick in. The Nevada Psychological Association conducted a survey of mental health providers in Nevada last year to ask about their experiences with the enforcement of mental health parity laws. They routinely reported to us that co-payments and deductibles for mental health benefits have significantly risen in the last number of years, making mental health care less affordable for all of our clients. Additionally, they reported that they had experienced increased denials for mental health care, requiring extra time to appeal the denials for necessary services. Many reported recoupments, which is when an insurance company takes back money they've already paid for claims when a utilization review committee subsequently denies the care. They noted difficulty getting credentialed, long wait times, being told that panels are full, while receiving calls from consumers looking for services who have been told that the provider was on their panel but is not. And then we have consistently lower reimbursement rates here in Nevada than in surrounding states. I waited over 9 months to be credentialed with one insurance company on the basis of, I waited over 9 months to be credentialed with one insurance company after they tried to deny my application on the basis of network adequacy. I'm a child and adolescent specialist. Every county in Nevada, as you have heard, it has a behavioral health care provider shortage, and Nevada ranks 51st in the nation for access to care for children. When I pointed out these facts, I was invited to credential with them for lower than Medicare standard rates. Psychological testing is another specialty in the field of psychology that allows us to conduct neuropsychological assessments of autism, ADHD, and learning disabilities, as well as provide complicated evaluations for individuals with multiple diagnoses, as well as for forensic purposes. This is another area that faces significant challenges. Most insurers impose such limitations on the time for administering, scoring, and interpreting tests that many providers cannot afford to bill for these services, and most consumers have to pay out of pocket to get the evaluations to allow their child to receive special education services, receive a clear diagnosis, be evaluated for dementia, or have their psychological status accurately identified in a court of law. Mental health parity is the law in Nevada and across the nation. Since the federal government required more compliance data from insurers in 2001, almost every state is finding areas of noncompliance with MPIA by insurance companies. That is true here in Nevada as well. In this bill, we're seeking accountability and transparency so that the data that is being collected here in Nevada can be used to improve access to care for mental and behavioral health services. Thank you.
Chair, with your permission, I'd like to do a walkthrough of the bill. Awesome. So we're going to go to section 1 all the way down to subsection 3A and B. What this does is in accordance with the system for electronic rate and filing developed by the National Association of Insurance Commissioners, puts that right in statute. Then if we go over to the next page, page 3, subsection 4, we can see that we added personally identifiable of information for consumers on there, making sure that we have our patients not being revealed for their information. And that is the bill as is. And Chair, with your permission, we are open for questions.
Thank you. We will start with Speaker Yeager.
Thank you, Chair, and congratulations on your first bill presentation. I think it went really well. Obviously, mental health parity is really important, and I just want to make sure I kind of understand what the bill is trying to do. So we have a federal law that requires mental health parity, and we also have federal laws that require insurance companies to present certain information when it comes to denial of claims. But what we're trying to do is say they should have to also report that information to the state. Is that essentially what the bill is attempting to do?
Spencer Flanders for the record. Chair Marzullo, through you to Speaker Yeager. So specifically,
you can go direct.
Thank you so much. So this information is currently being reported to the Division of Insurance. However, it is happening in various different forms. They're just kind of receiving memos. What we're trying to do is get a transparency piece so that the public can look at this information so we can do an analysis if they are upholding mental health parity. Thank you.
Thank you. And if I could ask a follow-up, please, Chair. I think that it makes it, you just want to standardize the information so that what's being reported to the federal government is the same that's being reported to the state. So I think I'm seeing heads nodding yes, but my question there is kind of twofold. Number one, and this might be a question for the Division of Insurance, so if it is, we can punt to them, but is there no way for the state to already get that information from the federal government? Is there like not information sharing that happens already? If you know.
I do not know for sure. Spencer Flanders for the record. I do not know for sure, but I'm happy to get you that information.
Thank you. And then one more, if I could. So the information, I think, is important. It helps us know what's going on. And again, this could be a question for the Division of Insurance, but I mean, what is the outcome? What is the remedy if what we learn through the reporting to the Division of Insurance is that, companies are not complying with a federal law on health parity? Is that something the Division of Insurance works on? Does the Attorney General step in? Does the individual have a claim? Does the insurance company have a claim? That's like a multi-part question. But I just sort of wondered, how does this work on the back end, on the state level, if we know someone's not complying with the law?
Lori Drucker, for the record, I'll take that one. I've been part of a statewide parity compliance task force for the last several months, and they talk frequently about these issues. My understanding is that under the current law, insurance companies, when they are found in violation of a parity reporting standard, they're given an opportunity to correct that, and that is the standard. So with the transparency, both consumers as well as providers and insurance companies know what is happening, and then it's on the insurance company to correct their standards. And then if they don't, then it looks at enforcement issues. Thank you.
Committee members, any additional questions? I don't see any. Great presentation, Assemblymember Cole.
Thank you so much.
We will begin with testimony in support of Assembly Bill 207. Is there anyone here in Carson City wishing to testify in support? Please remember to state and spell your name for the record. You have 2 minutes each.
Matt Robinson with Argenta Partners. I'm here today on behalf of Vegas Stronger, a nonprofit dedicated to delivering compassionate behavioral health care to underserved Nevadans, and we are in support of this bill for its efforts to bring the state into parity with the federal regulations. Thank you.
Hello, I'm Wesley Harper. I am the I'm the Director of Government Affairs for the City of North Las Vegas. Thank you, Chair. Thank you, Vice Chair, for this opportunity to be in support of this bill. The City of North Las Vegas believes that parity and mental health transparency, and in order to make sure that our residents get the same mental health as physical health, is important, and we appreciate the opportunity for support. Thank you.
Is there anyone else in Carson City wishing to testify in support? I don't see anyone in Las Vegas. Broadcast, is there anyone on the line?
Thank you, Chair. There are no callers to provide testimony at this time.
Thank you. We will move to testimony in opposition to Assembly Bill 207. Is there anyone here in Carson City wishing to testify in opposition? No one is coming up. No one is in Las Vegas. Broadcast, is there anyone on the line?
Chair, there are no callers to provide testimony at this time.
Thank you. We will move to testimony in neutral. Is there anyone here in Carson City? Welcome back.
Good afternoon again, Chair Marzola and Committee. Shelley Capurro representing the Nevada Association of Health Plans, and we are working with the sponsor and the proponents of the bill, and we're just working through some aspects of the proprietary information, and we're just looking at NRS 333.333. So that's what we're working through with them, and they are understanding the spirit of what we're looking for. So that's it.
Thank you. Is there anyone else in Carson City? No one in Las Vegas. Broadcast, is there anyone on the line wishing to testify in neutral?
Thank you, Chair. We do not have any callers to provide neutral testimony at this time.
Thank you. Assemblymember Cole, would you like to give any final remarks? I will now close the hearing on Assembly Bill 207. I will now open up for public comment. Please address your remarks to issues that fall within the jurisdiction of this committee. Public comment is limited to 2 minutes per person. Please remember to state and spell your name. Is there anyone here in Carson City wishing to provide public comment? Don't see anyone. Don't see anyone in Las Vegas. Broadcast, is there anyone on the line?
Thank you, Chair. The public lines are open and working. However, there are no callers at this time.
Thank you. Committee members, are there any final comments? I don't see any. This concludes our meeting for today. Our next meeting will be on Wednesday, March 5th at 1:30. This meeting's adjourned.